Welcome to the Byja radio show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kinba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. All right, we are back once again. Patient Zero coming in hot, as always, with these amazing musical entities. I don't even know what to call it. It's just these compositions are rare and unique. So let's give that man his flowers for that.
I appreciate it, man. I'm just trying to be like my doctor slash friend slash DJ when I grew up, man.
Tell me who that is. I don't know that guy.
Man, that's Byron. That's Byron K. Jasper. I will tell you what the K for, but I don't know if the people.
Yeah, we gotta keep that silent.
All right.
We don't want to put people on the edge of their seats and
right.
alarmingly scare them. But with that being said, welcome back. We are here for, I believe, episode 11.
Is it? Yeah, it's 11.
It's 11, man. So we are
checking it on.
We are now in the double digits quite conveniently. But I think it's helpful that right before this actual episode, we ran into a friend, but also someone who's a listener who told us that, look, I listened to your episode on sleep. And the episode on sleep was real helpful. All the stuff you said actually lines up. I'm doing more for my sleep, and it's actually helping me achieve all my health goals. So keep doing what you all are doing. So it goes to show that we're not just saying, hey, you should listen to this, you should do this. It's more so people are actually doing it, and they're coming in and actually telling us it actually works. Yeah. So kudos to you for listening to this amazing episode that is forthcoming. So, of course, as you all know, we are now looking at health topics. We usually kind of cover things from the direct primary care perspective, but this episode we're going to talk about something that I believe a lot of people deal with and may not quite understand what it is. They just know that it runs in their family, or people have had this issue that they take medicine for, but really don't have a good understanding of what it is. So we'll queue up the question as usual, and then we'll come back and talk more about what this unique and wide-ranging, almost affecting a lot of different people in a lot of different ways, this topic is about. So, George, if you don't mind, go ahead and cue it up for us.
Will do.
Hi, Dr. Jasper and Patient Zero. I enjoyed your episode about diabetes and diving deep into many of the items that comes with the diagnosis. Keeping that in mind, I've been told that high cholesterol can be a silent threat, but I don't know much about it. Can you both review what exactly is cholesterol, and why should men be particularly concerned about their cholesterol levels?
All right. So, again, very straightforward question, simple question, but nevertheless, it's a question about how is cholesterol a impactful thing, not only on this person, but their family, right? So based off of that, let's kind of start with the definition, if you don't mind. So, George, I'll start with you. Obviously, I can kind of go through the definition itself, but when you hear the word cholesterol, what do you think just off the top of your head, right? Sure. Not necessarily getting into the most scientific, but what do you think about cholesterol when you hear someone says anything about cholesterol? What is it? What do you think?
So for me, I think of a couple of things. First of all, first time I ever heard the word cholesterol, I was watching Liar Liar. You remember that movie?
Yes.
With Jim Carrey?
Hilarious.
And they had this bigger obese gentleman.
Yes.
Was like, hey, what's up, man? And Jim Carrey was like, you're a cholesterol fatty. So I've always identified cholesterol, or like elevated cholesterol, with obesity.
Yes.
And then obviously you hear the word cholesterol in foods. So I always put cholesterol with beef and cheese and all the delicious foods. So so that's the two things I think about.
Right.
Is meat, obviously, and obesity when I hear the word cholesterol.
Yeah. So I think that is the huge part that a lot of people think about, right? That, look, it's something that is a bad thing,
right?
But also it comes when you're eating certain foods. So that's pretty straightforward, and I think that's a standard thing. But the first thing that I think I want people to realize is what is actual cholesterol. The reason why I say that is we'll have people who will talk about diabetes, and if I say, what's diabetes? Most people know it has more to do with sugar, right? Like, a person has elevated sugar, right? And that's pretty safe to assume that diabetes is related to sugar.
Thanks.
But when you say, well, what is high cholesterol? People don't really know what that is. They just know it's bad, right? So cholesterol, for a definition, It's a waxy, fat-like substance that's found in the blood. That's pretty much what it is, right? So think about small particles of wax, candle wax, right? Just floating around in your blood. If you have that candle wax type of substance floating around in your blood, if it gets really, really bad, it can cause problems. But a lot of people don't realize that some cholesterol is actually a good thing, right? There are certain particles of cholesterol that can be helpful. So this waxy, fat-like substance that's found in the blood basically helps things when it's in the right proportion. And if it's in the wrong proportion, it could be a lot more harmful.
So is that good crackling? Is that good cholesterol in hog crackling?
I'll say there's good cholesterol in a lot of things. I'm not going to say hog crackling, though, because I know where you're going with it. Nice try. No. The idea is that there are types of cholesterol, and that waxy substance in the blood has a purpose. So the goal is not to eliminate all cholesterol, it's to keep it in moderation. Just like anything else, you need certain things in the body. Things that are too high can cause problems. Things being too low can cause problems. So you always want stuff in the right range. So the types of cholesterol we tend to know about are your total cholesterol, your triglycerides, and your HDL cholesterol, or high density lipoprotein cholesterol. So your HDL cholesterol is often called the good cholesterol. And then there's the LDL, the low density lipoprotein, which is your bad cholesterol. So again, most of the time you want good cholesterol to be high, you want bad cholesterol to be low. And what tends to happen, people often don't know this, is that HDL cholesterol actually works to remove bad cholesterol out of the body. So if you have enough HDL in your bloodstream, it actually helps to lower your LDL. But a lot of people don't realize that, hey, I want more HDL, not only because it's good cholesterol, but it actually helps to eliminate the need of medicine because the HDL is doing the work for you.
Sure.
So those 2 to 3 things are the things that a lot of people, when you hear I have high cholesterol, it's usually those 3 to 4 things that we're talking about. Total cholesterol, triglycerides, and HDL, plus or minus LDL. And if you're looking at those 3 to 4 things, usually you can tell if a person's having elevated cholesterol or normal cholesterol, and rarely low cholesterol, right? Now, again, the big thing to come back to is that what is cholesterol? Again, it's a waxy, fat-like substance floating in the bloodstream that has some purpose. Not always good, not always bad, but it has a purpose. So your goal is to keep it in moderation. Too low can be problematic, just like too high. And I think that is a huge driving point for this episode. If you're listening and you catch on to what are the health topics, hopefully when you leave here, you'll say, well, look, I do know I need to have some cholesterol in my body. I just don't want to have too much or too little. And I also know that cholesterol is basically like a waxy substance that's floating in the blood. And obviously too much of that substance can cause a problem.
Sure. Well, I hear waxy substance in my blood, and that sounds awful.
Yeah.
It sounds terrible. So like, what happens if I just get like a whole bunch of wax in my blood? Like what does that mean?
Yeah. Well, let's back up to another area of the body that a lot of people are familiar with the term wax. So when you think of wax, most of the time in a body place, earwax, right? Okay. So let's think about it. If you have a lot of earwax,
you can't hear
in your ear canal. Does your ear function the way it's supposed to?
You
can't, right? It's hard to hear. In real bad cases, it can affect your balance. It can affect your ability to actually know where you are in terms of depth perception, right? It's something really close to you, something far away. It can obviously cause issues with you knowing which way is left, right, up, down, right? So all of that being said, earwax can be a problem. So you can imagine that a waxy substance in your blood is going to be even more of a problem, because when you have that, what are the common things you think of if you have too much wax buildup in a blood vessel? It's a simple topic, simple concept, but if you have too much wax buildup in a body part, like a blood vessel, it causes a blood
blockage.
Clot, a blockage.
Oh, okay.
A clot or a blockage, right?
Sure.
So a blockage in a blood vessel is usually a problem.
I would assume so.
Right? Depends on where the blood vessel is. Some are more problematic than others.
Correct.
But the main causes of things like heart attacks and strokes often come because that fatty, waxy-like substance in your blood has built up so much that it blocks the vessel, so blood no longer can flow to where it needs to. That blood flow is blocked, so that vessel all of a sudden starts to either cause problems or it ruptures. And if it ruptures, now all of a sudden you have a huge problem on your hand. Because, of course, you have a ruptured blood vessel in your heart, it's a heart attack. Ruptured blood vessel in your brain, it's a stroke, right? You can also have ruptured blood vessels in other places that could be things like aneurysms. So all of those things be put together can be very problematic. But the goal of this is not only to say what could be the problem, it's more so, well, how do we address it, right? So we have talked about what is cholesterol. We talked about the parts of cholesterol. We've also talked about what can out of control cholesterol cause. So let's back up for a second and talk about what causes cholesterol to be out of whack. So you already talked about a few things. So I'm gonna give you an opportunity to talk about what are the things you think affect cholesterol levels. I know you already hit on one, but let's talk about others, right? Mm-hmm. So what is the first one you would say that can cause an elevated cholesterol level?
I would say your diet.
Okay.
So I would say, especially living in South Louisiana, we like to deep fry things. We make a roux and everything. We eat a bunch of sodium and all this other craziness.
That's delicious.
That's magically delicious.
Absolutely.
But I can't imagine that that's good for your cholesterol levels.
Yes. So that's the biggest and probably the most prominent, which is diet, and diet, right? So if your diet is extremely problematic, your cholesterol is going to be more than likely the same. Okay. So we know diet, most people get that one. All right. We got maybe about 5 more. So what other ones what other things can lead to elevated cholesterol besides a bad diet?
I would say obesity.
Okay, so obesity can, right? Because obesity contributes to fatty-like substances, right? Mm-hmm. So if you have a lot of obesity going on, more than likely you have excess fat on your body, in your body, within body parts. So if you have excess fat in the body, on your body, within the body parts, more than likely it can get into the bloodstream and cause problems. Mm-hmm. So diet, having extra weight on you, so obesity or morbidly obese, that can cause it. What else?
Being that you're obese, if you're not exercising, I would assume that kind of goes hand in hand.
Yeah.
You know what I mean?
Yeah. I think, again, spot on, right? So poor diet, and these things tend to kind of lend to one another. Yeah. Now, the issue is people kind of put them together. But no, you can literally still work out all the time. You can still not be obese, but still have a really bad diet. Yeah. And that can cause high cholesterol.
Yeah, I'm assuming if you in the gym every day, but you eating like Chewies for breakfast, it's not the healthiest.
Cheeseburgers, potato chips, things that are fried, French fries, right? All of these things lead to
French fries.
Yeah, who doesn't, right? But that's the point. So you can say, well, look, it's obvious if you're eating bad, then more than likely you're obese. And you can kind of lump them all together. But a lot of people don't realize that you can be extremely thin and still have high cholesterol.
True.
You can be extremely fit and have lots of muscles and go to the gym and still have high cholesterol. Mm-hmm. It's happened plenty of times where you'll have people who are young and apparently healthy appearing, and then they have a heart attack. And people have no idea why. And again, a lot of times they never have their cholesterol checked. They never have any idea what cholesterol is. They don't know what numbers may or may not need to be. Mm-hmm. And we'll talk about numbers and specifics in a moment. But I think overall you just hit the top 3. Diet, being very poor, that's 1. Being obese is 2, and then you just said lack of exercise is 3. So those are the trifecta, if you will, of high cholesterol. So I'll give you, let's say we got 3 more. Okay, what are the other 3 that would come to you that you may say, this may actually raise a cholesterol level? And it doesn't necessarily always have to be the common things, but what uncommon things you would say if it's out of those top 3?
Well, I got another common thing. I feel like everything bad health-wise can be tied back to like smoking.
Absolutely, right?
There's nothing there's nothing positive in your health that smoking attributes to.
Yeah, my favorite response when I hear people when they say, "Well, why do you smoke?" Well, it calms my nerves down, and it's like, okay, I'm not even trying to like argue because
it's calming them and frying them at the same time.
It's calming your nerves down, but also making you deathly ill at the same time. So while your nerves are calm, everything else is getting
creating
worse.
More problems.
Exactly. So you're robbing Peter to pay Paul, as they say. So anyways, smoking is a huge factor in raising cholesterol, which people don't think about that because you're like, well, again, when you oftentimes are smoking cigarettes or tobacco related products, most of the time there's a bunch of stuff in the actual cigarette that can lend to more waxy like substance being put into the blood.
Very true.
So once you're smoking something that can put more waxy like substances in your bloodstream, it raises your cholesterol. So smokers tend to have higher cholesterol. So that's another one. All right, 2 more. Well, you already got one. So most of the time when you say smoking, there's the second thing that comes right after smoking.
Don't say it.
Go ahead.
Don't say it.
I already know you know it. It's okay. It's okay. It's going to be okay. Alcohol, absolutely. The thing that a lot of us potentially enjoy, but don't realize that it comes at a cost.
Does whiskey elevate your...
Absolutely. 100%. One of the biggest ones.
Lord Jesus.
A lot of alcohol can do it, right? And the goal in anything alcohol related is moderation, right? If you're having excess alcohol, it's going to cause excess problems.
What's excess alcohol?
Well, the recommendation, and again, there's a bunch of information, bunch of places. The recommendation usually is 2 glasses of fill in the blank in a day.
Oh, okay.
That's it. 2.
All right.
All right. In a day. Now, 2 doesn't mean the cup you fill up. It's usually measured in ounces. So if a alcoholic beverage is usually somewhere between 4 to 6 ounces, that's not a solo cup. That's not a bottle.
So, okay. So 4 to 6 ounces. So let's say 4.
Mm-hmm.
So that's 8 ounces a day. So I could drink 56 ounces of whiskey in a week.
You could.
It'd be good.
You could. But it's usually 2 per sitting, right? Not per day, but per sitting. Yeah. And from there, if you're doing that, more than likely you're okay. Now, it's not a one size fits all. Everybody's different. But yes, that's the point. A lot of people don't know about moderation. They think, well, I had 2 drinks. But they had the equivalent of 20 ounces. And in their mind, 2 10-ounce cups is 2 drinks. But they haven't done the math to realize that if it's a 4-ounce count and you had 20 ounces, that's actually 5 drinks, right? And now you're over here wondering, well, why is my number so high? I only had 2 glasses, but your glasses, your pores are extremely heavy. And when
you was at tailgate, you had like 1 Stanley cup of...
Absolutely. And I know a lot of people who do it all the time, and they'll sit down in the exam room and they're like, well, I don't have that much to drink. And if I really press them on, well, how many ounces, no one knows, right? No one measures in ounces, even though they should. Mm-hmm. And what they end up doing is drinking an excess amount and not realizing that's contributing to their elevated cholesterol or their damage to their liver and things of that nature. So, of course, alcohol. But more importantly, excess alcohol. That is number, 5 I think we're on? So we got one more that everyone often overlooks. You said diet, you said exercise, you said smoking, you said alcohol, and you said obesity. So I'll give you all those. What is the last one that mostly everyone forgets about?
Maybe other conditions?
Well, I'd say yes, but pre-existing or comorbid conditions are ways that we say it. That usually affects you. Anything outside of you that you think may contribute to your cholesterol level? No pressure.
I don't know. Stress. I don't know.
Well, I'm going to say it's more obvious than you think. It's called family history.
Oh, yeah, I should have known that.
Right. Most people should, right? But they don't think about that.
Yeah, I should have known
It's
that.
who you're potentially related to, right? So more than likely, if your parents have issues with cholesterol, your siblings have issues with cholesterol, you're going to have that problem too, because it just runs in the family. And a lot of people don't think that, but it's basically a genetic composition. So sometimes you may say, well, how did I develop high cholesterol and I don't really do all of these things? I don't drink a lot, I don't smoke a lot, but my cholesterol is elevated. Well, the body is going to do what it does, because if everyone could stay healthy just by doing nothing, then everybody would live forever. But things are going to change as you get older, and some of that is just related to who you are, who is in your family, where you're growing up. So of course, genetics play a part. And when you put all these things together, it's not a one size fits all. So you may say, well, look, I only have 2 drinks, but this person has 7 and their cholesterol is great, but mine isn't. Well, you also have to factor in, do you smoke? Do they not smoke? Are you exercising? Do they exercise? Do you have a family history? Do they not? And all of these factors get put together. And when you do that, you start to get this picture of high cholesterol or not. When you have all those things figured out, it tends to turn into a very specific thing that we're trying to narrow down. And when we narrow it down, we start talking about, okay, are your numbers high? If they are high, what are the reasons? And how do we address it? Well, of course, adjusting all of the stuff we just talked about. Taking the diet back, being more active, doing things in a way that will allow you to eliminate obesity, cutting back on drinking, eliminating smoking, all of those things that you can adjust are usually the ways that we want to lower cholesterol in a more natural way. However, if you can't do those things naturally, or you're doing them and it's still not working, What do we end up having to do? Well, we have to do medicine. Now, before we get into medicine, let's talk about numbers. So we talked about the 2 to 3 levels that tend to go into cholesterol. All right, so let's talk about numbers that may or may not be a good a good rule of thumb to kind of keep in mind when it comes to cholesterol levels. So let's start with total cholesterol. What would you think would be a good number for a total cholesterol in terms of above or below, right? So what number would you say, this is a number that if I'm above this number, I have high cholesterol in a total cholesterol sense, versus if I'm under this number, I'm normal. So that is a very loaded question, but I think you should know this because we've checked your numbers and we've had this talk before. So I want to see if you can remember this actual number. So what number would you say, my friend?
Total cholesterol. I would say total would be between 100 and 199.
So it seems very specific. Any idea why, my friend? So just so you all know, George is loading the deck. He's pulling up his lab values and reading the actual numbers.
They sound crazy on the radio.
I thought you were just gonna give me a round number.
Hey,
so
man,
you would have did better. You would have did better just saying 200.
Hey, so I'm just saying, bro, as patient zero and as somebody who's the first person in the clinic,
you got to know this.
I gotta know this. And look,
yeah,
but shout out to Byja Clinic because
we provide.
I was able to get to my numbers fairly quickly.
Yeah.
You know what I mean? Because I just got them. I got them handy.
There you go. Right, and that's important because a lot of patients don't have that. We'll say, "What are your numbers?" and they can't put their hands on them.
Yeah,
they're trying to log in and they can't actually look at them. You can look at them pretty quickly, so that's good. But you hit the number on the head. Depending on the lab, it's usually somewhere between 100 to 200 is what I say. If you're between 100 to 200, you're normal. Anything above 200 in your total cholesterol is considered elevated.
Yep.
So when you have a person coming in that's above 200, it doesn't automatically mean they need to be on medication, but it does mean that they need to consider,
they need to do something.
Are they high to where they need to be on a treatment of some form, a better diet, more exercise, stopping the drinking, less smoking, taking medicine, or do they need to obviously say, hey, my numbers are great, they're under 200, I'm good. So based off of that, above 200 for total cholesterol. Let's go into triglycerides. What would be a high triglyceride number and what would be normal? So above this is high, under this is considered normal. What would you say?
I would say 150 would be high.
Okay, so anything above 150 is high.
Anything above 150.
Anything above 150 is high. So absolutely. Now this is the trick question I'm going to see. What can cause triglycerides to be elevated when you have your labs checked?
Hard crackling.
Well, of course, food, right? So what we tend to do, people will say, well, why do I need to come in fasting for labs? Well, what tends to happen is triglycerides will be elevated when you eat. And if you're eating within a certain time frame, it can give a false sense of it being elevated. So that's why we want you to come in fasting, because that can change and shift very quickly. The total cholesterol doesn't really change as much when you eat. Neither does the HDL, but your triglycerides often spike when you eat, especially when you eat hog crackling like George does. And when you do that, it then spikes the triglycerides. Triglycerides are spiked, it can mess up all your other levels as well, which we'll talk about in a second. But yes, anything above 150 is considered high. Okay, let's talk about HDL. HDL is backwards. We just said we want more HDL and we want other numbers to be a little bit lower. So what HDL level do you tend to look at and say, I want to have my HDL above this level, which is a good thing because it protects the heart, it protects the blood, it keeps the other cholesterol levels at bay. So what HDL level do you want to be above?
You want it to be 40 and above.
Okay, so 40 and above in males. Females have a different number, and if I remember correctly, I think in females you want their number to be even higher. You want theirs to be above 45. And I'll be honest, I'm not an expert at the heart. This is definitely when you start getting into the lipidologist or the cardiologist. They might tell you this is why we want more HDL in a female versus a male. If I had to take a guess, an educated guess, it's because you want to have more protection because maybe the female heart is not as strong in terms of that ability to fight off heart attack, strokes. Now, do not quote me on that, and I say that because if I don't know, I'm a great doctor to tell you I don't know. I will absolutely go and look it up and confirm. But in this recording, since we record live and we're very honest and transparent, I'm not 100% sure why absolutely you want this number to be higher, but I do know women's numbers tend to need to be higher in order for it to be considered normal.
So you're going to go with their hearts may not be quite as physically strong to fight off heart attacks and strokes. I'm going to go with the fact that they have an extra rib. They need the extra good cholesterol.
So you going biblical is what I'm hearing.
I read the book.
There you go.
I know what's in the good book.
So I'm not going to say you're wrong. All I'm going to say
We'll
is
see.
We'll look it up and see.
Yeah, and we'll see
look
who's
it up and
right.
see. Yep. So the idea, and again, it's been a while since I looked into the range of which one is higher, which one's lower, and who needs what and why. But I do have a feeling that the overall point is when you look at those two numbers, you want to know that there's a slight difference. So total cholesterols and triglycerides need to be about the same for women compared to men. HDL is the slight difference because we want those to be slightly different for male versus female.
So we have a friendly wager on this, and we're going to do a whiskey wager. Whoever's closer, you get 2 ounces. And since we're doing this cholesterol podcast, we're going to be strict on ounces.
2 ounces?
2 ounces of whiskey.
So who wins gets 2 ounces or who loses?
Who wins gets 2 ounces.
Okay, I'm just making sure. I wanted to make sure
Get
that
2 ounces.
because I didn't know if it was like more punishment for getting it wrong.
No, whiskey's delightful.
Yeah. So all things considered, if it is indeed that we want the HDL to be higher in women because it needs to remove the excess bad cholesterol, and if we're removing excess bad cholesterol, it helps us avoid heart attacks, then that may be the case. But the idea is that women's HDL level tends to need to be higher in order for it to be normal. So you may be able to be normal at 42, but a female patient may need to be at 49 because I believe with males is 40 and females tends to be 45 or above. Okay, so a slight difference, but the goal is higher HDL usually is more protective. That's the big take home. Finally, the LDL, which is the bad cholesterol, and this is probably the one that most people tend to focus on, which I'm not going to say is a bad thing, but I do think it's something you want to know about. So what is the LDL level we tend to tell people we want them to be under to consider having a normal value?
Under 100.
Under 100, yep. So it's pretty good to remember that number. Now, in some instances, you will say anything above 130 is considered high, and when you start needing medication. But 100 is a good rule of thumb that once you're above 100, you're starting to go into the bad area. So you might not necessarily get medicine at 102 or 110 or 115, but you may start to say, hey, you're at 110, 115, 120. It's pretty inevitable that medicine is coming if we don't get this under control.
Correct.
All right, so we got 100 to 200 for total cholesterol. That's usually normal. Under 150 for triglycerides is normal. Above 40 for males, above 45 for females for HDL, and then less than 100 for LDL when it comes to both sides. So those numbers are kind of the hard and fast rule. Different labs have maybe a little bit of variation. So if you go to lab company A versus lab company B, there may be a slight difference. It may be 100 to 199 versus 100 to 200. It may be 152 versus 150. It may be 110 versus 100, but the goal is we want those numbers to be close to those ranges. When those numbers are higher and consistently higher, that's when we start talking about needing to do treatment. And of course, treatment that most people think about is medication. So again, we're not going to go into a long episode on medication, but what I do want to consider is that there are a multitude of medications that can potentially help with lowering cholesterol.
Correct.
A different amount other than what people tend to know, which is basically the family that most people end up on are called statin therapy. Statin therapy are things like your rosuvastatin, your simvastatin, your atorvastatin, your lovastatin, your pravastatin. So anything ending in statin tends to be the go-to. And it's because they're pretty good medicine, they're pretty safe, pretty effective. They do have side effects like any other medication, and you definitely want to be mindful of those side effects. Things like muscle aches, muscle cramps, liver damage, those are the common things you'll see, not the only things, but different people have sensitivities to these medicines. Outside of that, there are a bunch of other lipid-lowering medicines. Lipid is another name for cholesterol. So lipid-lowering medications that are out there that are both pills, and most recently, there are now injectable cholesterol medications. And the cholesterol medications that are injectable are obviously probably a little bit better in terms of less pills, so you don't have to worry about taking them every day. Some of them you can take once every 2 weeks. So you take one shot and it lasts 2 weeks. Some you actually take once every 6 months. So you have these very high potency, very effective cholesterol medications that may now eliminate you having to take pills, and then your cholesterol is lowered for 6 months. Now, that doesn't mean you can literally take medicine and go eat and drink whatever you want, which I have a lot of patients who do that. I have people who literally come to me on cholesterol medicine. And when they come, what do you think the first thing they say? Well, I don't realize why my cholesterol is still high if I'm taking the medicine every day. And they often eliminate, they don't exercise, they haven't improved their diet, and they're not actively working to lower their cholesterol. They just think I'm taking the medicine, it should do everything for me. Well, in these injectable cases, it may do a lot better a job of lowering it, but if you're working against the medicine, it doesn't really help. So that is a huge part that I think a lot of people need to know. And I think it's something that a lot of people tend to potentially have a surprise element when we kind of go in and say, I'm checking your cholesterol, you've been fasting, and even though you're taking this every day, your numbers are still high. So I'll come back to you, George, and I'm going to ask a few more quick questions, and then we'll slowly start to wrap up with this episode. Based off of the conversation we've had so far, what are your estimated time frames of when we potentially should check cholesterol to see if there is a improvement from level A versus level B? Do you think we need to check it once a week, once a month, once a year? How often would you say is a good rule of thumb to recheck cholesterol if we're looking for an improvement or to see if it's gotten worse?
Well, cholesterol, I don't think that's one of those things that just change overnight, right? So I normally get my blood work once a quarter, like clockwork. So I would say once a quarter is good, unless I'm just super healthy.
Yeah. So once every 3 months or once a quarter is actually a pretty decent rate, but it's usually every 6 months to a year, right? It depends on the person. Some people check more often, and they check more often because, hey, we want to make sure these numbers are good and they're not getting in the wrong direction. But if a number is really safe, really standard, I've been on this medicine, my numbers are great, I'm exercising, I'm eating right, my numbers are great, we don't need to check stuff as often. So a good rule of thumb is every 3 to 6 months if a person has elevations and we're trying to adjust their medicines and get it under control. But if a person's doing well and the numbers are good and healthy, it's either 6 months to a year. Okay. So that's one thing. Based off of that, if you are indeed on medications, my other question to you is, we've already talked about it. What are the other things that you want to do besides taking medicine that would potentially help to lower the cholesterol collectively?
Well, you got to manage your diet and eat, and obviously exercise, I would assume, and control your weight.
Yep.
So
those,
which is harder, easier said than done.
Easier said than done, absolutely. So that's it. And I think the other thing to consider is, you already touched on it, and I'm happy you didn't say it, but it gives us an opportunity to highlight it, is managing stress, right? Because if we're trying to lower cholesterol, the idea is, hey, we want to eat better, we want to exercise, we want to try to cut out the drinking, maybe the smoking. Keeping the stress level down also helps potentially with cholesterol not being excessively built up. Because again, when you're having a lot of stress, you're going to do what? Make bad decisions. You're going to end up drinking to help you feel better. You're going to potentially eat things that may not necessarily be helpful. So you want to really and truthfully think about, let me make sure I'm trying to keep this stress under control, which allows me to make better decisions. There's one more thing I want to be specific about that helps to lower cholesterol that a lot of people don't think about, and it is diet related. But I want to be very specific on what can help to lower cholesterol from a diet standpoint of putting more of this into the diet. What will help you lower your cholesterol? Any thoughts?
I would say, so it's a type of food. I would say leafy vegetables and maybe white fish.
Okay. So you're being very specific, which I'm going to go ahead and applaud you and mentally say you are on it. I think I should be a little more.
I just had a salad.
No, I think you're great. No, and I'm going to literally give you your props on that because you hit a few of the things in a very specific way. But the concept that I was trying to get at is fiber.
Oh, okay.
Right? You said leafy vegetables, and usually vegetables tend to have more fiber, right?
What about raisins?
Raisins especially, right? So this is a conversation we talk about, and maybe we'll do a whole episode on it, but maybe it's perfect for this segment. High fiber diets are probably some of the best diets out. Now, it's not saying it's going to fix everything, but when you have more fiber in your diet, 2 to 3 things tend to happen. Number one, you tend to have more bowel movements. If you have more bowel movements, the stuff you're eating tends to come out a lot faster, which allows it not to hang around the body and cause problems. Number two, it tends to fill you up faster. So you're less likely to overeat or eat excessively, because when you eat a lot of fiber, the foods tend to seem more bulky, and the bulky stuff in the belly tends to make you feel full. And number three, fiber helps you to lower cholesterol. When you have more bowel movements, fiber tends to bind to the bad cholesterol and take it out of the body. So normally if I tell a person you have a low fiber diet, you're going to have more problems with other things in your body. A lot of people don't know what that means. Well, this is one of the things, cholesterol. So tend to tell people, hey, you need to eat more fiber. You get more fiber, your cholesterol will lower in a very natural way. It's a way to potentially eliminate absolutely needing medicine. It's not saying it's going to be the end all be all, but if you say, look, I'm working out, I'm eating better, and I'm actually trying to lower my cholesterol without taking medicine, what do I need to put into my body? Fiber. And if you're eating enough fiber, that allows you to lower your cholesterol in a natural way. So my question to you, my friend, what is considered a high fiber diet in terms of the number of grams you need in a daily dose, right? How much fiber do you need in a day to consider having a high fiber diet? Now, again, let me paint the picture. You come, you sit down, you say, hey, doc, what are my labs? I say, hey, your cholesterol is actually high. You say, I don't want to take medicine. What do? I say, well, you need to eat a high fiber diet. You can walk out the door in a traditional practice and say, well, whatever that means, right? Because, okay, I'm used to eating no fiber. I eat one salad, so that's high fiber. It must be, right? No, not necessarily. So what is the number that we're trying to achieve when we say a high fiber diet?
I'm going to go with 40 grams a day.
Okay, so that's actually above the amount, but it actually is good. It's actually 25 to 30.
Okay.
25 to 30 grams of fiber. So if you're eating 25 to 30 grams of fiber daily, that's considered a high fiber diet. And that is important because you just asked the question. You said, hey, are raisins considered high fiber? My response was yes. The issue is we'll have people come in and say, I'm eating things that have fiber in them, but don't know how much fiber. I eat raisins, but don't know how much fiber a raisin has. And why do I say that? What I then tell people is not only do you need to know what a high fiber diet is in terms of the amount of grams, but you then need to know how many servings equate to that number of grams. So eating one raisin doesn't automatically give you the full serving of fiber, but that's what people do. I ate an apple,
Right.
and all of a sudden they think they have hit this magical fiber number. So you need to know what a serving is of this fruit or vegetable that gives you high fiber.
But you could make me cook a pot of lentils tonight, man.
Lentils are actually pretty high. I was looking at it yesterday because I had a patient who came in and they needed to get a high fiber diet for a number of reasons. Lentils, beans, prunes, and raisins tend to be the higher ones. Things like celery and broccoli, those aren't bad, but they don't have a ton of fiber in them compared to these others. And if I tell you you eat a serving of beans and it gives you 14 grams of fiber compared to you ate an apple and it gave you 2, you may feel like, well, look, I do eat a lot of fruits and vegetables and I'm eating a lot of fiber. And then you come in and you realize it's 7 grams and you're still short 18 grams of fiber, right? So it's getting into the mindset that we really got to be meticulous on this measurement, because if our goal is to lower that LDL, lower that total cholesterol, raise that HDL, we have to absolutely be mindful of what we're putting into the body and be very meticulous on that. Okay. So we now know high fiber helps to lower cholesterol. We know what a high fiber diet is, 25 to 30 grams. And we know that we have to be meticulous on what foods have fiber compared to other foods and what is a serving. And if you do that, believe it or not, you can lower cholesterol pretty effectively, but it has to be consistent as well. You can't eat one good salad, one pot of lentils, one pot of beans, and then all of a sudden your fiber is through the roof for one day and then it drops down to nothing for the next 6. And you say, well, why is my cholesterol not getting where it needs to be? Well, it's because we're not consistent in those numbers. And again, this takes time. You just said, how long does it take to potentially see a change? 3 to 6 months. If we're looking for a change in 1 to 2 days, 1 to 2 weeks, good luck. It's not going to move that quickly. But over the course of months, if not 3 to 6 months, right? Almost a half a year, you can hopefully see a positive change if you're consistent in those behaviors.
Yep.
So I think we are pretty much good on this topic, right? We talked about cholesterol. We talked about what's high, what's low. We talked about what cholesterol is. We talked about what are the factors that contribute to elevated cholesterol. We talked about how to potentially lower it. And I think more importantly, we talked about ways that people are potentially going to see cholesterol affecting them if they don't necessarily make those adjustments and the numbers get out of whack. So anything else, George, question-wise that you may have as we talk about this, that you say, look, I'm thinking about this in this very specific way. This came to mind as we were talking about things.
No, I mean, I think you're very clear. You kind of put me on the spot there, man. But you're always very thorough. So, you always explain things, especially in my visits, to where I thoroughly understand these things. And I'm glad we're having this conversation, because I'm going to kind of, change my diet a little bit, just get some more fiber.
Well, I think it's great.
Yeah.
I think it's great for you to do that. But I think the other thing that is pretty important is that a lot of doctors don't have time to talk like this. Right. We just spent roughly 40 to 45 minutes talking about one topic. In a normal, routine, traditional primary care visit, how much time do you think you would get for me to talk to you about your cholesterol?
You get 7 minutes to talk about everything.
Everything, right? So if I tell you your cholesterol is high and you have questions about it, what do you think I'm going to tell you?
Hey, I'm going to send you an email.
I'm going to go ahead and look it up, right?
Right.
Well, I'll send you a handout, or I'll print it out and give it to you. And in that conversation, you're in essence given the accountability, which we talked about on another episode. But the problem then turns into, well, what if I have a follow-up question?
Right.
So what do you do for that follow-up? Well, I got to make another appointment. And then I got to hope that in that next 7 minutes, I can get all my questions out, which you don't have time to really kind of go back and forth about fiber, about genetic risk factors,
Thanks.
about alcohol and what's an actual number of alcohol from an ounce standpoint that is safe and healthy, if you will. So that's why I think, we talk about direct primary care, but we're also talking about it in a way of, hey, we really want to be thorough and detailed on all of these things. And we haven't even really and truthfully went into really over the top detail of certain topics. There are certain tests that we didn't touch on that are actually very helpful beyond the traditional lipid study. The lipid study we just talked about, which is the total cholesterol, the triglyceride, the HDL, the LDL. There are things like the apolipoprotein B test. And that test talks about your risk factor for basically how close are you to developing a heart attack from a cholesterol standpoint. That's a test that's actually pretty inexpensive to do within our practice that we do on certain patients, but we don't send up there and do it on everyone because it may not be necessary.
Correct.
If your numbers are really low, you don't need it. But if your numbers are excessively high, you do, because we want to say, hey, this is how close you are to having a heart attack. It's not just you have high cholesterol, but this number now puts you at an even higher risk of having a heart attack. So we need to really aggressively get this down. Some people don't even know that exists because we don't have time to talk about it. And we don't know if the insurance will cover it. And if your insurance doesn't cover it, you get a crazy bill. And that crazy bill can be $400 for that test. And you have any idea how much that test really costs?
I don't know, like $30?
$10.
Jesus Christ.
So it's crazy, but we'll order that test, do the cash pay pricing, if you will, through our clinic, and tell someone, look, if you don't change, you're going to have a heart attack. And we're able to do that in a more effective way in the model. So huge benefit with the direct primary care angle as usual. But overall, I think we are hitting all those high points. So with that, I believe we are slowly but surely going to close out. So George, with that wrap up that we are now at, I'm going to go ahead and turn it over to you to say what the thoughts you want to share with the listeners about today's episode, or just about things in general.
Sure. I would say with this episode and all our episodes, really, just take the information and just take control of your health. Because I have you as my physician, but everybody doesn't have you as their physician. And even having you as my physician, being a wealth of information, and I don't have to go look up things like maybe some other people might have to do. I still have to physically carry out, the instructions, right? I gotta eat better. I gotta do this different. I gotta take this medicine. I gotta take accountability for my own health. So I would say, listen to this episode, listen to all our others, and when you hear things when you have that aha moment where you think, well, hey, maybe I didn't realize this, or hey, maybe I wasn't aware of this, look it up, check your numbers, know your numbers, have access to what you got going on, and adjust accordingly. Because at the end of the day, man, we are dealt with specific hands that we're dealt with. Like for me personally, I have my own hereditary things. I grew up in South Louisiana where the food's good, everybody got a roux and all this other good stuff.
Yep.
And I have 39 years, going on 40 years of that type of food in my body, and I have to adjust and adapt accordingly. So I would say take control of your own health and do what you need to do.
Well, let me ask a question, because I know you're giving your closing thoughts, but it kind of gave me an idea of something I think is helpful to work into potentially your closing thought. You said you have 30 some odd years potentially of this type of food. What do you think about people who have relatives that have heart disease and strokes? How does that potentially factor into your closing thoughts? Do you think that's something people need to think about?
Yeah, absolutely.
Right.
Absolutely, that's something you need to think about, man. If you live in South Louisiana, you had grandparents, parents who had heart issues.
I would say anywhere.
Or anywhere,
right?
Or you have people who've had certain cancers or whatever you're dealt with. Look into that.
Absolutely.
Just because you don't have the numbers or you don't have the diagnosis,
or you're young,
or you're young,
right.
You still need to be aware of the fact that this might happen, and you need to be taking charge of that and doing whatever you can to circumvent that type of outcome, right? So be aware of your situation because you're different from everybody else.
Yeah. And I agree, and that's part of the reason why I was asking that question of you, is because what I've heard people say is, well, so-and-so had a heart attack and they were in their 30s or 40s. So-and-so passed away and they're in their 30s or 40s. And then the follow-up question for me is, well, is that something that runs in the family, especially if we're talking in exam standpoint and we're having an actual clinic visit? And a lot of people will say, oh, I don't know. We don't talk about that. We don't have conversations about health in my family because, no one really wants to have that conversation.
Correct.
But I think that happens because no one really wants to ask the question. We don't want to talk about, well, so-and-so had a heart attack and they were this old. So-and-so had a stroke and they were this old. So-and-so had an issue with diabetes and they were this old. And that tends to lend to long-term health issues in a family, generation after generation.
But if you're fortunate enough to where you're one of these people who have your relatives, right? You have your parents, you have your grandparents, your aunts and uncles, your cousins, all these people. Have that conversation with them. Be like, hey, you know what? Is there any hereditary issues that I need to be aware of? Grandma passed away. What happened?
Absolutely.
Like just know that and understand. Hey, maybe once I get to that age, or maybe even before that, I'm susceptible to this.
Yeah.
You know what I'm saying? So, just have those conversations, especially if you're blessed enough to have your people in your life. Ask the questions.
Yeah. And it's going to potentially be uncomfortable until it's not. You're going to possibly have people not want to talk to you about their health issues, but the more you do it from a genuine place, like, look, I'm not trying to get into your business. I'm trying to do this to see how I can prevent this from happening to me or to your grandchild or to my sibling. And in order for me to be better, I need to know certain things. That conversation is huge, and it's paramount for a lot of people to have those conversations sooner rather than later, because it's nothing short of, and I'll tell this story and then we'll again hopefully close out, unless obviously something strikes us. But I had a young lady come and see me. She had private insurance, and then she lost her insurance because her job status changed. When she lost her insurance, she came to me and we started taking care of her. Young lady has a history of diabetes, high blood pressure, and high cholesterol. She's also a smoker. With that being said, we did something called an ASCVD risk calculator or score. The ASCVD stands for atherosclerotic cardiovascular disease. So atherosclerosis is basically when you start to have blood vessels that end up having problems, whether it's being overly calcified or having fatty issues like cholesterol. And the score is telling you what's the risk of them having a bad outcome due to atherosclerosis. Okay, so basically, if you're having a heart or blood vessel or a vascular issue due to something that you're doing, diabetes, smoking, right? What is the likelihood you're going to have a bad outcome as a result of your cholesterol level, your blood pressure, all that. So we put all this stuff in. Again, the young lady had high blood pressure, high cholesterol, is a diabetic and a smoker. We calculate on a scale of 0 to 100% her risk of having a bad outcome, stroke, heart attack, something like that. Do you have an idea what her risk calculation score was when we saw her on her first day?
And what's the scale?
0% to 100%. Like
97.
That would have been really bad. It was 83. 83%.
I heard smoker, so I just always assume everything's like
it's 10 times worse, right? But this is the point. Within 2 weeks of us getting her on the right blood pressure medicine, lowering her cholesterol by putting her on the right medicines, and actively addressing her issues, her risk factor score dropped down to 36.
Wow.
2 weeks.
50%.
2 weeks. Literally 2 weeks of getting good care eliminated her risk of having a heart attack or stroke by a vast amount, as you just heard me say. You went from 83 to 36.
That's 47%.
Right. You see my point of why the closeout that you're saying is so paramount of, look, you can't just walk in thinking, well, look, I got time. I'm going to get to it when I get to it. My stress level is high, but I'm going to take care of it when I get time.
I know some people who ain't make it.
Absolutely.
Like there's people I went to college with, and there's people that were around my age that have died
100%
from natural causes. I'm not talking about people who got car accidents, people got murdered, anything like that. I'm talking about people in real life have died from like heart issues or some type of disease or some type of thing. And you know, I never want to point the finger at somebody, but you never know, man. Like, you don't know what you don't know.
Don't know.
And it's like had some of these individuals known their numbers or known what was going on, they might have been able to prevent death. You know what I'm saying, or at least prolong it for some years. You know what I mean? Because, you know, like when sometimes your blood pressure gets up there, you don't know.
Yeah.
You know, you don't know you got high cholesterol. You don't feel it.
You don't feel it.
You know, so it's like you gotta be proactive and check these things out, because you can't have the mentality that we talked about a few weeks back, where, you know, like, all right, I feel good and I'm wrong. You know, like I feel good, I don't need to go to the doctor. Nah, bro, like, you know, you feel good till you don't. And if you got some of these underlying things, you could prevent yourself from dealing with these issues. So just, I would say, check yourself out. Like, if you take away nothing else, know your numbers, check them out twice a year.
Easily.
And just see what's going on.
Yeah. And I'll put the proverbial icing on the cake, if you will. You just said exactly what I think a lot of people don't do. I feel fine, so I must be fine. Right? My car runs fine, so I don't need to get the oil change. It's fine, right? Sure, right?
Yeah, until that engine to lock up.
Until all of a sudden it's not.
Right.
The problem is we're waiting for a symptom to tell us to go to the doctor rather than being proactive and checking. And then we're talking about treatment of a sick or a chronic issue rather than prevention.
Correct.
So at this point, to close out, I think, you know, George hit on it, I hit on it. It's getting in care with someone who really and truthfully takes time to make you feel comfortable, answer your questions, and do it in a way that you can effectively feel better. But not just saying and doing it because it's supposedly convenient, but saying and doing it because you know you're going to get a better outcome. Lowering that ASCVD risk score from 83 to 36% is life-changing. Because if you're 83%, it's 83% likely that you're going to have a heart attack or a stroke. You think that that's just going to put itself off for another 10, 15? Like, it could happen at any point. But if you're 36% more likely, then hey, I take 36 over 83 any day. And all it took was to add some medicine, change some lifestyle related factors, and then obviously get in care. So all that being said, we're going to slowly but surely close out. But George looked like he has something that just came to him, so I'm going to give it back to him.
Nah, man, nothing episode related. I'm just thinking, why you like 36?
36%? Why is it 36%?
No, it's just the number 36 in general. So, you know, that's the one thing I was thinking. Nothing.
I know what you're talking about.
Nothing episode related.
I understand exactly what you're talking about. So outside of that, which a lot of people won't catch unless you're a member of a very prestigious fraternity, which will kind of kick that to another episode.
Right.
But Speaking of that, shout out to Brother Bokaj. He actually gave us a shout out on LinkedIn. He
Yes,
said
sir.
great episode, so we appreciate you for listening. And anybody else, again, we do recognize and see these comments, these positive things. We try to shout out people where we can. And overall, we just appreciate the love, appreciate the support, appreciate you sharing, subscribing, reposting, all that good stuff.
And if you got a question for us, please hit us up, ask the question.
That's the point.
And what I'll do is I'll try to answer the question first.
I actually think,
and then hand it over to Dr. Jasper.
I actually think you do answer the questions very well, especially when you get to pull up reference points in the lab values that we are.
Hey man, you know.
The pop quiz happens and you go and pull out the cheat sheet.
I know my numbers.
That's a good thing. That's a good thing, right? That's a good thing. So with that, we'll close out. So George, in this episode, where can the people find you after the episode?
They can find me on Instagram at Becnel Media. You can also find me on X, Twitter at George_Becnel.
X Twitter. That's a new one.
X Twitter or Twitter's X.
Twitter's X. That's what I was thinking.
I don't know. Twitter's ex-girlfriend. Elon Musk is ex. I don't know.
They're not
Cybertruck.
vibing no more.
I don't know.
There you go. I got you.
I don't know.
You can find us on the clinic at www.byja.org, on Instagram and Facebook at Byja Clinic, all one word. You can also find us on LinkedIn under Byja Clinic. You can find me under my Instagram account at drbjasper, all one word, Dr. B. Jasper. And the news that we are potentially drawing closer to, we are starting a nonprofit division of our direct primary care practice.
Yep.
Patient Zero is well aware of this. He's been helping us behind the scenes work on this, but the goal for us with the nonprofit division is to literally offer this model to the underserved and people who may not be able to afford it, and if not offer the model in full, offer services to people in the underserved community. So if you are interested in helping us with that, definitely reach out on our website. You can find the contact information, shoot us an email. We'd love to obviously partner with people to try to get that off the ground. So far, we're doing pretty well, but we want to continue to grow that. The name of that nonprofit is Byja Charitable Alliance, which pairs with Byja Clinic. Again, we're getting all the stuff together infrastructure-wise, so be on the lookout for that. More info on that will be forthcoming. Outside of that, next week, we're going to try to definitely bang out an episode for everyone. I am traveling next week. I'm headed to the great city of Dallas. I am doing a couple of presentations on direct primary care to some doctors and some hopeful people moving into the model. So we'll be out doing that. And if we're able to knock out an episode before we head and travel to Dallas, we'll do that. If not, we will see you in 2 weeks. But either way, we appreciate you for listening. Thank you for being supportive, and we will definitely be back in the near future.